What are the key considerations when administering opioids to a pediatric patient for postoperative pain management? Explain the principles involved in determining the appropriate opioid choice, dosage, and monitoring parameters. Answer. When administering opioids to pediatric patients, key considerations include the child's age, weight, medical history, and the severity of pain. Opioids should be used cautiously due to the risk of respiratory depression, sedation, and potential for misuse. A thorough assessment of the child's pain, including the use of pediatric pain scales such as the Wong-Baker FACS scale or FL8CC scale, is essential to guide opioid dosing. Dosage should be adjusted according to age-specific guidelines, and the smallest effective dose should be used. Opioid doses are typically weight-based, with careful attention to the appropriate route of administration, oral, IV, subcutaneous, etc. The Pediatric Opioid Safety Guidelines CDC guidelines on opioid prescribing emphasize careful monitoring for adverse effects such as respiratory depression. Monitoring should include assessing pain relief, sedation levels, and signs of opioid toxicity. Chronic pain conditions like juvenile arthritis can significantly affect a child's quality of life. What is the approach to managing a pediatric patient with chronic pain from juvenile arthritis, and how does this differ from managing acute pain? Answer. Managing chronic pain, such as in juvenile arthritis, requires a comprehensive, multidisciplinary approach. Unlike acute pain, which is typically treated with short-term interventions, chronic pain necessitates ongoing pharmacologic and non-pharmacologic therapies. Pharmacologic treatment may include non-steroidal anti-inflammatory drugs, NSAIDs, disease-modifying antihepatic drugs, DMARDs, and biologics to address the underlying inflammation. Opioids are generally avoided due to the long-term risks, focusing instead on medications that manage inflammation and pain. Non-pharmacologic strategies, including physical therapy, cognitive behavioral therapy (CBT), and biofeedback, are crucial for helping the child cope with pain. Regular assessments using pediatric pain scales combined with family involvement ensure optimal pain management. Chronic pain management also includes education about the condition, medication adherence, and lifestyle modifications. What are the key components of parental education when preparing a family for discharge after a pediatric patient undergoes surgery? Answer. Parental education is crucial for ensuring the smooth transition from hospital to home after pediatric surgery. Key components include explanation of the surgical procedure and post-operative care. Parents should understand the surgery's purpose, expected recovery, and signs of complications, e.g. infection, bleeding, pain management. Detailed instructions on administering pain relief medications, including both pharmacologic, e.g. acetaminophen, ibuprofen, and non-pharmacologic options, e.g. warm compress, distraction techniques, wound care. Proper care of the surgical site, including dressing changes and recognizing signs of infection. Follow-up care, scheduling follow-up appointments, understanding when to seek medical attention and how to handle emergency situations. Family dynamics and emotional support, discussing the emotional needs of both the child and family members during recovery and providing resources for sibling support if needed. Explain the role of cognitive behavioral strategies in managing pain for pediatric patients, particularly in children undergoing minor medical procedures. Provide examples of these strategies and their rationale. Answer. Cognitive behavioral strategies, CBT, play a key role in managing pain by helping pediatric patients alter their perception of pain, reduce anxiety, and increase their ability to cope with discomfort. In children undergoing minor procedures, strategies like distraction, e.g. listening to music, watching videos, or using virtual reality and guided imagery, e.g. imagining a favorite place or activity, can be used to divert attention away from the pain. Other CBT techniques include relaxation exercises, e.g. deep breathing, and positive reinforcement for cooperating during procedures. These strategies reduce the child's anxiety, making the experience less traumatic and potentially decreasing the need for pharmacologic pain relief. The rationale behind CBT is to utilize the mind-body connection to reduce the perception of pain and to empower children to manage their discomfort effectively. Mrs. Thompson's 5-year-old daughter is undergoing surgery for a congenital heart defect. Mrs. Thompson has a 3-year-old son, Jason, who is very close to his sister. What strategies should the pediatric nurse recommend to Mrs. Thompson to help Jason cope with his sister's hospitalization and surgery? Answer. The pediatric nurse should suggest the following strategies to help Jason cope with his sister's surgery. Honest communication. Explain the surgery in simple, age-appropriate language, emphasizing that his sister will be okay and that the surgery will help her feel better. Involvement. Allow Jason to be involved in the process, such as drawing a picture for his sister or choosing a get-well card. This helps him feel included and reduces feelings of powerlessness. Provide reassurance. Let Jason know that his feelings are normal and that it is okay to miss his sister or feel worried. Maintain routines. Try to keep Jason's daily routine as consistent as possible, including regular meals, bedtime, and playtime to reduce stress and anxiety. Provide emotional outlets. Encourage Jason to express his emotions through play, drawing, or talking, and consider involving him in family discussions post-surgery to keep him informed. By addressing his emotional needs and involving him in the process, Jason will feel more secure and less anxious about the situation. Describe how the FLACC scale is used to assess pain in nonverbal pediatric patients. What are the key elements of this scale, and how do they help in the evaluation of pain intensity? Answer. The FLACC scale is a behavioral pain assessment tool used for nonverbal children or those unable to communicate their pain. It evaluates pain intensity based on 5 categories: face, expression of discomfort such as grimacing, clenching of the jaw or frowning, legs, movement or tension in the legs such as kicking or drawing them up, activity, level of restlessness or activity, G, squirming, inability to stay still, cry, vocalizations including whimpering or crying, consolability, how easily the child can be comforted or soothed. Each category is rated on a scale from 0 to 2 with a total score range of 0, 1, 0. A higher score indicates more intense pain. This scale helps nurses assess pain in infants, toddlers, and nonverbal children by observing their behaviors, enabling timely interventions for pain relief. Postoperative pain management in pediatric patients often involves a combination of pharmacologic and non-pharmacologic strategies. Discuss the key considerations for pediatric nurses when creating an individualized post-surgical pain management plan for a child. Answer. An individualized post-surgical pain management plan for pediatric patients should consider several factors. Age and developmental stage. Pain assessment tools and management techniques should be age-appropriate. Younger children may require more non-pharmacologic interventions such as distraction, while older children may benefit from a combination of medications and cognitive behavioral strategies. Type of surgery. The level of pain will depend on the surgical procedure. More invasive surgeries may require stronger analgesia. Pain assessment. Ongoing pain assessment using age-appropriate pain scales is crucial for monitoring pain levels and adjusting interventions accordingly. Pharmacologic interventions. The use of acetaminophen, NSAIDs, and opioids should be based on the severity of pain and the child's age and weight. Opioids should be used cautiously with appropriate dosing and monitoring for side effects. Non-pharmacologic interventions. Techniques such as distraction, relaxation, G, deep breathing and positioning, G, propping the child in a comfortable way can complement pharmacologic treatments. Explain the importance of family involvement in pediatric care and discuss how the nurse can support family-centered care during a hospitalization. Answer. Family-centered care, FCC, emphasizes the active participation of the family in the child's healthcare decisions and care. This approach recognizes the family as the child's primary support system and aims to enhance both the family and child's experience in the healthcare setting. Nurses can support FCC by encouraging family participation, involve family members in care planning and decision-making, such as discussing treatment options and setting goals for recovery. Effective communication. Provide clear and honest information about the child's condition and care plan and encourage families to ask questions. Emotional support. Recognize the emotional needs of the family, especially when the child is undergoing major procedures or treatments. Provide resources like social work support or counseling, addressing family dynamics. Understanding the family's structure, cultural background, and support system can help tailor care to their needs and preferences. A case where a pediatric patient's family is facing significant stress due to financial and emotional challenges. What are the nurse's roles in addressing family dynamics and providing support? Answer. In cases where families are experiencing financial or emotional stress, the pediatric nurse plays a crucial role in providing holistic support by assessing the family's emotional needs, listening to concerns and acknowledging the stresses the family is facing, providing resource referrals, connecting families to social work services, community resources, or financial assistance programs to ease the burden, supporting parental involvement, encouraging active participation in the child's care while acknowledging that stress may affect the parent's ability to engage, offering emotional support, providing a safe space for parents to express their fears and concerns and offering reassurance and guidance to reduce anxiety, fostering collaboration, engaging other members of the healthcare team, G. Child life specialists, social workers, to ensure that the family's emotional, psychological, and practical needs are met. What are the emotional impacts of a sibling's hospitalization on young children, and how can pediatric nurses mitigate these effects? Answer. Siblings of hospitalized children often experience a range of emotions, including fear, confusion, jealousy, and neglect. These feelings may arise due to the altered family dynamics and the focus on the ill child. Pediatric nurses can mitigate these effects by providing age-appropriate explanations, explaining the situation in simple terms, emphasizing that the sibling will recover and return home soon, offering opportunities for involvement, encouraging siblings to participate in activities like drawing cards or visiting the hospitalized child if appropriate, maintaining normalcy, ensuring that the sibling's daily routine is as stable as possible to reduce feelings of insecurity, emotional validation, acknowledging the sibling's feelings and providing emotional outlets for them to express themselves, family support, offering family counseling or resources to help all family members cope with the stress of hospitalization. What is the legal process and the responsibilities of a pediatric nurse when suspecting child abuse or neglect, and how do mandatory reporting laws protect the child's welfare while also balancing the nurse's professional duty? Answer. Mandatory reporting laws require healthcare professionals, including pediatric nurses, to report suspected child abuse or neglect to the appropriate authorities such as Child Protective Services or law enforcement. These laws are designed to protect vulnerable children and ensure their safety by enabling timely intervention. The legal obligation stems from statutes in each state or jurisdiction that outline who is required to report e.g. nurses, doctors, teachers, and the procedure for making a report. The pediatric nurse must report suspicions based on reasonable cause or observation, even if no definitive proof exists. Failure to report could result in criminal charges or civil penalties. Legal reference. The Child Abuse Prevention and Treatment Act, CAPTA, a federal law providing guidelines for the mandatory reporting of child abuse. State laws. Each state has its own child abuse reporting laws that define the responsibilities and protections for healthcare professionals. Why is it crucial for pediatric nurses to follow best practices in documenting patient information in electronic health records, EHR, and what legal consequences might arise from failure to do so? Answer. Proper documentation in HR systems is essential for providing high-quality care, communicating with the care team, and ensuring that a legal record exists in the event of litigation. Inaccurate or incomplete documentation can lead to serious legal consequences, including malpractice, suits, or charges of negligence. The nurse must ensure that all entries are accurate, timely, and signed by the appropriate provider. Also, any corrections made should follow the appropriate legal procedure, such as adding an addendum rather than simply deleting or overwriting the original entry. Legal reference. Health Insurance Portability and Accountability Act, HIPAA, requires maintaining accurate and confidential health records. The Joint Committee (EJC) provides guidelines for healthcare organizations regarding documentation practices. A pediatric nurse is working in a low-income community and notices that many of her patients are unable to access needed pediatric specialties due to lack of insurance. How should the nurse approach advocacy in this situation, and what are the legal and ethical considerations? Answer. In this scenario, the nurse should advocate for the rights of the patients by identifying and addressing systemic barriers to care, such as lack of insurance coverage. This could involve collaborating with social workers or case managers to assist families in finding affordable resources, applying for insurance coverage, or seeking out sliding-scale clinics. Additionally, the nurse can participate in efforts to influence policy by educating the public and lawmakers about the importance of accessible pediatric care for all children. Ethical considerations. The nurse's duty to advocate for the child's well-being aligns with the ethical principles of justice, fairness, and beneficence. Doing good. Legal reference. Affordable Care Act, ACA, provides provisions to expand insurance coverage and reduce barriers to care, especially in underserved communities. A pediatric nurse is reviewing a study to inform the care of a child with asthma. What factors should the nurse consider to assess the validity and applicability of the study's findings to the clinical setting? Answer. To assess the validity of a study, the nurse should evaluate study design. Is it a randomized controlled trial RET cohort study or observational study? RCTS generally provide stronger evidence. Sample size. Was the study powered sufficiently to detect meaningful differences? Bias and confounding variables. Are the study results free from bias, or could confounding factors have influenced the outcome? Results consistency. Are the results consistent across different populations or settings? To determine applicability, the nurse should consider whether the population in the study matches the patient demographic in the clinical setting, e.g., age, comorbidities, Clinical guidelines. The nurse should integrate the evidence with their clinical expertise and the patient's values as per the evidence-based practice EP model. Sarah is a 16-year-old patient admitted to the hospital for surgery to treat a congenital heart defect. Her parents are not available to provide consent due to travel abroad. The surgical team is asking the pediatric nurse whether they can proceed without parental consent. What steps should the nurse take in this situation? Answer: in this scenario, the nurse should follow the legal and ethical principles surrounding informed consent for minors. In most cases, a minor under 18 cannot provide full legal consent for medical procedures unless they meet certain criteria, e.g. emancipated minor or mature minor laws in some jurisdictions. If the minor is not legally able to give consent, parental or guardian consent is typically required. However, in an emergency situation where waiting for parental consent would delay necessary treatment, the doctrine of implied consent may allow the healthcare team to proceed with the procedure, assuming immediate intervention is needed to save the child's life or prevent serious harm. Legal reference: the American Academy of Pediatrics Guidelines for medical consent, including emergency situations. State laws. Some states have mature minor laws allowing minors to consent to certain medical treatments, particularly in the case of life-threatening emergencies. How should a pediatric nurse apply recommendations from the American Academy of Pediatrics when developing a care plan for a child with type 1 diabetes? Answer: the pediatric nurse should integrate OPS clinical guidelines for type 1 diabetes management, which typically include insulin therapy, prescribing appropriate insulin regimens and dosage based on blood glucose monitoring, dietary guidelines, encouraging a balanced diet with special attention to carbohydrate counting, monitoring, regular checks of blood glucose levels and AC levels, education, teaching the child and family about the signs of hypo and hypoglycemia and how to manage both, clinical practice. Nurses should also ensure that the recommendations are up to date with the latest evidence-based research and tailored to the individual child's needs. Legal reference: American Academy of Pediatrics provides evidence-based guidelines for managing chronic conditions in children. A pediatric nurse at a hospital notices a rise in post-operative infections in pediatric patients. What steps should the nurse take to identify the root cause of the infections and initiate a quality improvement process to address this issue? Answer: the nurse should first gather and analyze data, including infection rates, patient demographics, types of procedures, and potential risk factors. This analysis helps identify whether the issue is related to a specific procedure, nursing practice, or hospital-wide policy. Once the root cause is identified, the nurse should collaborate with the quality improvement team to develop a hypothesis, e.g., are infection control protocols being followed, implement interventions, e.g., stricter adherence to sterilization procedures, monitor the outcomes through continuous data collection to assess the effectiveness of the changes. QI tools use tools like Plan, Do, Study Act, PDSA to monitor the success of the intervention. Legal reference: the Joint Commission, Standards for Infection Prevention and Control in Pediatric Care Settings. What is the significance of accurate and comprehensive charting in pediatric nursing practice, and what risks are associated with incomplete or inaccurate documentation? Answer: accurate charting is crucial for ensuring continuity of care, facilitating communication among healthcare providers, and providing a legal record of care. Inaccurate documentation can lead to miscommunication between healthcare providers, poor patient outcomes, and legal liability. Nurses should ensure that each chart entry is clear, complete, and reflects the patient's status and nursing interventions. Legal risks: if a case goes to court, improper documentation can be used as evidence of negligence or breach of the standard of care. Legal reference: the Joint Commission's National Patient Safety Goals outlines the importance of accurate patient records. In cases where pediatric patients face discrimination based on race or socioeconomic status, how can pediatric nurses advocate for their rights within the healthcare system? Answer: pediatric nurses must recognize and address healthcare disparities by advocating for equal access to care for all pediatric patients, regardless of their background. This includes ensuring that all patients have access to the resources they need, such as specialty care and medications, educating families about their rights and available resources to help overcome systemic barriers, engaging in policy advocacy to influence legislative changes that promote equity in pediatric healthcare. Ethical considerations: this aligns with the ethical principles of justice and advocacy, ensuring that all patients are treated equitably. Legal reference: Title VI of the Civil Rights Act of 1964 prohibits discrimination in healthcare based on race, color, or national origin. A pediatric nurse is reviewing the hospital's care protocols for the management of asthma in children. What should the nurse consider when updating these protocols, and how can evidence-based research be integrated into the process? Answer: when updating care protocols, a nurse should review the latest clinical research on asthma management from reputable sources like the American Academy of Pediatrics OP and Global Initiative for Asthma (GINA). Ensure that new evidence regarding medications, monitoring techniques, and non-pharmacological treatments are incorporated into the protocol. Collaborate with multidisciplinary teams to discuss changes in evidence-based practices and ensure that all team members are trained on new protocols. Legal reference: AAP Asthma Guidelines offers comprehensive recommendations for managing pediatric asthma based on the latest evidence. Describe the steps involved in the neonatal resuscitation protocol (NRP) for a newborn who is not breathing effectively after delivery, and explain the rationale for these steps. Answer: the neonatal resuscitation protocol (NRP) follows a series of steps to assess and manage a newborn who is not breathing effectively. Initial assessment: immediately after birth, the newborn is assessed for breathing, heart rate and tone, positioning and suctioning. Ensure the infant's airway is clear and suction the mouth and nose if necessary. Drying and warming: dry the newborn and provide warmth to prevent hypothermia. Ventilation: if the infant is not breathing or has a heart rate below 100 beats per minute, BPM begin positive. Pressure, ventilation, PPV. Chest compressions: if the heart rate remains below 60 BPM after 30 seconds of effective ventilation, begin chest compressions. Epinephrine: administer epinephrine if the heart rate remains below 60 BPM despite chest compressions. The rationale behind these steps is to quickly restore the infant's respiratory and cardiovascular stability, minimizing the risk of brain damage or death. What are the primary differences in managing trauma in infants, toddlers, and school-aged children, and why does the approach differ? Answer: management of trauma differs across age groups due to developmental and physiological differences. In infants 0–1 year, trauma often involves head injuries or suffocation risks. The management approach focuses on maintaining airway patency, preventing hypothermia, and using age-appropriate resuscitation methods, e.g. smaller endotracheal tubes. For toddlers 1–3 years, the approach includes not only airway management but also addressing developmental concerns like separation anxiety and minimizing pain. Common injuries include falls and fractures, and the use of pediatric-specific splints is crucial. For school-aged children 4–2 years, trauma management focuses more on assessing for internal injuries, e.g. abdominal trauma, and providing psychological support for stressors related to the child's understanding of the injury. The differences in approach are due to the varied anatomical, physiological, and psychological stages of development, which influence both the response to injury and the management strategies. What are the guidelines for handling and administering vaccines to infants, and why is it crucial to follow these guidelines? Answer: vaccines must be handled according to strict guidelines to ensure their effectiveness and safety. The general guidelines for vaccine administration in infants include storage. Vaccines must be stored at the recommended temperature ranges, usually refrigerated or frozen. Administration technique: use the correct needle size and site for injection. For infants, the vastus lateralis muscle is typically used for IM injections. Timing: vaccines should be administered according to the recommended vaccination schedule to ensure optimal protection. Monitoring for reactions: after administration, the infant should be monitored for any immediate allergic reactions, e.g. anaphylaxis. Following these guidelines ensures that vaccines are effective and that the risk of complications from improper storage, handling, or administration is minimized. How do you assess and manage a head injury in a pediatric patient, and what are the key signs to monitor for that could indicate a serious head injury? Answer: assessment of head injury in a pediatric patient begins with a detailed history including the mechanism of injury. Key signs to monitor include consciousness level. Is the child alert, drowsy, or unresponsive? Pupillary response. Dilated or unequal pupils may indicate increased intracranial pressure. Vomiting. Persistent vomiting after a head injury could indicate a concussion or more severe brain injury. Seizures. New onset seizures after a head injury may indicate a serious intracranial injury. Management includes stabilizing the airway, ensuring adequate oxygenation, and preventing further harm. If signs of increased intracranial pressure are evident, immediate imaging, e.g. CT scan, and referral to a pediatric neurosurgeon may be required. What are the key considerations when choosing a route of medication administration for a pediatric patient, and why might a nurse choose to administer medication intravenously instead of orally? Answer: The choice of medication in pediatrics depends on several factors, including age of the child. Infants and younger children may have difficulty swallowing oral medications, requiring alternative routes like nasogastric or intravenous administration. Type of medication. Some medications, such as antibiotics, may be more effective when administered intravenously due to better bioavailability and faster action. Clinical condition. If the child is vomiting or unable to absorb medication through the gastrointestinal tract, intravenous administration ensures the drug reaches the bloodstream effectively. For example, if an infant requires antibiotics for a severe infection and is unable to tolerate oral medications, an intravenous route is chosen to ensure rapid and effective treatment. What factors should be considered when determining the appropriate analgesic, e.g. acetaminophen or ibuprofen, dose for a pediatric patient, and how would you manage a situation where the recommended dosage exceeds the safe maximum dose? Answer: when determining the appropriate analgesic dose for a pediatric patient, several factors must be considered. Age and weight of the child. Pediatric doses are often calculated based on the child's weight and DG or age. The child's clinical condition. For example, children with liver disease may require a reduced dose of acetaminophen due to its hepatic metabolism. The medication's pharmacokinetics and side effects. For instance, acetaminophen is metabolized by the liver and can cause hepatotoxicity in overdose, while ibuprofen is metabolized by the kidneys and can cause nephrotoxicity if used improperly. In situations where the recommended dose exceeds the safe maximum dose, e.g. a high fever requiring high doses of acetaminophen, it is critical to reassess the need for medication. Ensure that the clinical condition justifies the dose. Administer the lowest effective dose. If possible, adjust the frequency or choose an alternative analgesic with a lower dose. Monitor closely for any signs of overdose or side effects, such as jaundice in acetaminophen overdose or decreased urine output in ibuprofen overdose. What is the immediate treatment for pediatric anaphylaxis, and why is it important to administer epinephrine promptly in these situations? Answer: the immediate treatment for pediatric anaphylaxis includes the following steps. Administer epinephrine. This is the first-line treatment for anaphylaxis. Epinephrine works by constricting blood vessels to reduce swelling, improving blood pressure, and dilating airways to relieve breathing difficulties. It should be administered intramuscularly into the outer thigh as soon as anaphylaxis is suspected, even before the child reaches the hospital. Monitor the child's airway and breathing. Administer oxygen if needed and provide support to maintain a clear airway. Additional medications, antihistamines, e.g. diphenhydramine, and corticosteroids, e.g. prednisone, may be used for symptom relief, but these should not delay epinephrine administration. Repeat epinephrine if necessary. If symptoms do not resolve or return, another dose of epinephrine should be administered every 5 minutes. Administering epinephrine promptly is crucial because anaphylaxis can progress rapidly, leading to severe respiratory distress and cardiovascular collapse. Delaying treatment can result in an increased risk of morbidity and mortality. Describe the Pediatric Advanced Life Support (PALS) algorithm for pediatric cardiac arrest, focusing on the key differences in resuscitation for infants and older children. Answer: the Pediatric Advanced Life Support (PALS) algorithm for cardiac arrest follows a systematic approach, though it differs for infants and older children in the following key ways. Initial assessment. For both infants and older children, the first step is to assess responsiveness and initiate CPR if the child is unresponsive and not breathing. Chest compressions. For infants under 1 year, compressions should be performed with 2 fingers at the center of the chest, just below the nipple line. For children over 1 year, compressions are performed with 1 or 2 hands depending on the size of the child. Defibrillation. Infants under 1 year who experience a shockable rhythm should receive a shock with a manual defibrillator set to a dose of 2. Children over 1 year may also require defibrillation with an initial shock of 2 for JG. If using an AED, follow the device's specific guidelines for pediatric shock. Medication administration. Epinephrine 0.0 mg/IVO is administered every 5 minutes during the resuscitation process for both age groups. Amiodarone or lidocaine may be used if the child's rhythm remains shockable after several defibrillation attempts. The major differences between resuscitation in infants and older children involve the techniques for chest compressions and the equipment used for defibrillation. What are the most critical components of trauma assessment in pediatric patients, and how does it differ from the approach used in adults? Answer: the trauma assessment in pediatric patients includes several critical components that differ from adults due to anatomical and physiological differences. Initial assessment. The ABCD Approach airway, breathe in, circulation, disability, exposure is the standard airway. Ensure the airway is open and if necessary, use airway adjuncts such as a pediatric sized oral airway. Breathing, assess for signs of respiratory distress and provide supplemental oxygen if needed. Circulation, check for signs of shock such as delayed capillary refill and initiate IV access for fluid resuscitation. Disability, perform a quick neurological assessment e.g. Glasgow Coma Scale. Exposure, remove the child's clothing to assess for other injuries while preventing hypothermia. Differences in approach. Anatomical considerations. Children have larger heads relative to their bodies, making them more prone to head and neck injuries. Additionally, their rib cages are more flexible, which can lead to less obvious signs of thoracic injuries. Physiological considerations. Children's cardiovascular systems are more dependent on maintaining blood volume and they often compensate well for hypovolemia until a critical point. Therefore, early signs of shock may be subtle and should be closely monitored. Pediatric-specific concerns. Head injuries. Since children's brains are still developing, head injuries can have significant long-term effects. Pain management. Administering pain relief should be considered early in the assessment, taking into account age-appropriate methods e.g. oral or IV analgesics, regional blocks. Why might a pediatric nurse choose intravenous Roman administration over oral or intramuscular routes for administering medications to a child, and what are the risks associated with each route? Answer. A pediatric nurse may choose intravenous Roman administration over oral or intramuscular routes for several reasons. Rapid onset of action. IV administration provides the most immediate therapeutic effect as the medication is delivered directly into the bloodstream, bypassing the gastrointestinal tract. Absorption concerns. In children, particularly those who are vomiting or have compromised absorption, e.g. in cases of dehydration or gastrointestinal illness, IV administration ensures that the medication is absorbed effectively. Control over dosage. IV administration allows precise control over the exact dose delivered to the patient. However, each route carries potential risks. Oral administration, while safe and convenient, it is subject to variable absorption, especially in infants and younger children. IM administration. This route may be painful and difficult in children who may resist or move, causing inaccurate dosing or trauma to the injection site. Additionally, IM injections may cause local tissue reactions. IV administration. Though effective, it requires careful monitoring to avoid complications such as infiltration, extravasation, or thrombophlebitis.